One. Please start, sir. We are live.
Okay.
Yeah.
So respected doctors, first let me introduce our speaker today. Good evening, respected doctors. It is a great pleasure to welcome Dr. Sujit to our today's eyesight meeting. He is a renowned ear consultant of Guwahati. Currently, he is practicing in Guwahati and Tripura Hospital. He is from Medical College Liverpool. After that, he is PG ML from RIO Guwahati. He also did from ASD Guwahati, and he did also his short-term medical fellowship from LVPI Vijayawada. So let's welcome Dr. Sujit Reddy sir for his presentation. He will deliver the talk on comparative analysis of anti-VGFs, protocol to evidence. Sir, please continue.
Yeah, thank you, Dhruva, for your introduction. So, good evening to everyone. So, we'll straightway talk a few lines. And
Sir, you
uh,
sir,
uh,
please sir, switch on.
please, what? Can you hear me? Dhruva, am I audible?
Yes, sir. Yes, sir.
Yeah, I can continue now. I think Dhruva's
Yes,
network
sir.
is
You can
some problem.
continue.
Yeah, so thank you so much, Veer, for allowing me to have a go on this. So my topic is a comparative analysis of anti-VEGFs and particularly in diabetic macular edema. So as we know, as you see from the picture, is that the global burden of diabetes will continue to increase. And if you see the color-coded photo, you can easily see that Africa and Southeast Asia are the worst affected continents. In Southeast Asia, the meanness will increase because we are basically rice-eating populations. So, because our food habit, we will continue to have higher number of diabetes, and a lot of people will get affected in the long term. And on the global scenario, if you see, there is a estimated 51% increase by 2045, and highest will be affected continents will be African and our Southeast Asia. So vision loss in DME can have life-changing consequences. I've been told to read slide by slide, so I'll try to catch all these slides, the main point. So usually diabetes is a disease that destroys a family. I have seen people, the bread earner having diabetic retinopathy complications. One, he cannot act to the fullest potential, and number two, every month and for a long time, do a year, he has financial implications that he has to come and monthly and get treated. And thirdly, the results are very slow. So those three factors make the DME a very, very um, having it makes a very difficult disease for the patient who are having suffering from it. So it has difficulties performing near vision, all tasks you'll find difficulty. His driving and all mobilities, all this is compromised. There, apart from the eye, is mortality is the risk of mortality is also increased. And what does it bring? It brings a sense of gloom, sense of depression to the patient. So I see diabetes is having an what I say that it has a very fatal effect on the patient and also his family, because most of the bread earners are affected and the whole family has to suffer for it. So patient with DME are typical of working age, so that vision loss reduces independence, productivity, and ability to perform daily functions. So as a result, the family suffers. So this slide is talks about the pathophysiology, how the diabetes do act. So basically, it acts through two main receptors, that is vascular endothelial growth factor and placental growth factor. As we all know, this is a very common slide that how does it affect? It increases the vascular permeability and hypoxia, inflammation. They are the two basic factors. They play important role, and all those drugs which we will be pondering till today, they act on those pathways, the inflammatory pathway, the neovascularization pathway. So all the drugs, they target as the receptors. So the drug which can act, which can block all the receptors is a better drug compared to a drug which can block only one or two receptors. So Eylea is a complete. We'll talk in this regard. So you see, aflibercept significantly decreased intraocular VEGF and PIGA, placental growth factor levels from baseline to the month 2 in patient with DME, and that's why it is the drug. And nowadays, I tell that Eylea is the last line of defense. I try all the molecules, all the drugs, and then at last I tell them that we have the Ramban, that's called Eylea. Let us try it, and not because they are. I am speaking on behalf of them. I can tell you that in last 1 year, I have a lot of cases in Guwahati and Tezpur. So Eylea patients, always Eylea has given us the results. So I can regulate with one of the Bollywood movie, Lakshya, in which Amitabh Bachchan has said that every time the Rajputana regiment is given a task, it always has given the nation good news. Forget about the sacrifices has done the regiment. So till for me, Eylea till today is like a molecule which has always given me the results. So that is apart from all those things, I have to admit regarding the Eylea, because it affects all the receptors. Definitely, it will have some effect. It will always have a good news from the patient. So as I told, is only widely approved agent that will block all VEGF1R ligands and key VEGFR ligand. So all these receptors, they are the mediator of all the pathways in diabetic macular edema, like the inflammatory neovascularization pathway, retinal vascular leakage in edema. So as aflibercept can block all the pathways. So always and every time till now, we have got some results. In most of the cases, we have very great results. So you compare aflibercept with other bolucidumab, faricimab, or ranibizumab, because they had a they control, they don't block all the pathways at it simultaneously. So their action, their results will always be inferior to aflibercept. It is from the histopathological point of view. So yes, so you see, always we have pondered on we have already stressed on the fact that which receptors act on which pathway. So you can easily see that binding target for Eylea on the left hand side is VEGF-A and PIGF, and that is why its efficacy in stopping the inflammatory pathway and in giving us good results from the vision point of view is far better than ranibizumab or bolucidumab or you say faricimab. So that is the chart that demonstrates the ligand binding capacity of the aflibercept molecule. So this is only globally available anti-angiogenic drug that targets all VEGFR ligands, including the distinct pathway of VEGF and PIGF. Now all these slides will be regarding the protocol part. So protocol T was a randomized head-to-head trial of anti-VEGF agents for treatment of visual impairment of DME, and what he found that with aflibercept, the vision gains are superior to those with ranibizumab and bevacizumab, because it's very clear from the all those discussions that since aflibercept can block all the possible pathways of which are known to us till today, so obviously it will be superior to other molecules which are available with us like bevacizumab or ranibizumab. And clinically meaningful vision gains with aflibercept were maintained through the year regardless of the patient baseline visions. In this context, I want to tell you that it is my personal view that all the anti-VEGFs, they can reduce central retinal thickness, consequently can improve the vision. But only aflibercept we have seen it can repair the retinal lines. I don't know how theoretically it can be helpful for you, but from a physician point of view, I have many OCTs which I have shown to Dhruva also. Even I have talked with all my junior colleagues who are in touch with me that how aflibercept can give you result even in those cases where it has been given multiple other anti-VEGFs with no meaningful results. I have seen that retinal layers have been repaired by aflibercept, and I have heard that your prices are coming down from April. I can assure you that you people will be much more benefited with this molecule till a new and better comes. I think aflibercept will come, and it will be straight fight between Eylea and other molecule, because I can understand that aflibercept can repair retinal lines. So I think you will have some good days to come, because from April we are making more affordable for the patients. And at 1 year, Eylea demonstrated advantages over other comparator, basically ranibizumab and bevacizumab, and vision gains with aflibercept about 2 years of superior, and it could maintain the gain lines, because in retina part, the doctor must understand that initial gain is not the most important. It is the maintenance of the gain, because patient tends to lose interest in the doctor and the treatment if the gain that were achieved are not maintained subsequently. Because we cannot tell the patient every time and all the time that you have injection. We have to give them injection-free time, that you are fine now, you come after 6 months, you come after 1 year. In our setup, patient decides. Even if I call him after 3 months, patient will never turn up. They will say, Doctor sir, I am fine for last 1 year. Only for last 15 days I have problem, I come to you. So we have to give them a disease-free interval, so that the patient understand the importance of the treatment and come back to us whenever he or she feels that the vision has come down. In this context, I can tell you that Eylea can maintain those gain lines. All the other anti-VEGFs will ensure a gain, but maintenance time is lesser compared to Eylea. So VISTA studies has demonstrated that aflibercept can significantly improve retinal perfusion in DME. So that's nothing surprising, because as the inflammatory part comes down, patient have more blood supply. Consequently, all the other improvements we have found. And VISTA study also have shown a significant portion of patients treated with aflibercept experience improvement in DR severity. The chart will always shows us that proportion of patients who have more than 2-step improvement in diabetics retinopathy severity scale. So, in a post hoc analysis, we find with DM in PDR, aflibercept has achieved greater rate of improvement of DR severity compared to the others. And Clarity study evaluated the efficacy, and they found that superior base corrected visual gains were achieved with aflibercept. Versus this is a study, the theoretical study. So there is no match between laser and anti-VEGF, because laser destroys the area. It finishes the area. It doesn't give any chance so that we can modify the area. So because it is theoretical study done, I'm reading it. But obviously anti-VEGF, as I say, that they can repair the area. So we are giving a chance that the damaged area can be repaired and we can get some vision from that area. Laser that destroys the area. So obviously and definitely all anti-VEGF will be better than PRP, not only in aflibercept. So what you found that in real world with DME, aflibercept can achieve clinically meaningful visions and maintain vision regardless of the baseline vision. That's the most important part. I must tell that in my initial years, I have lot of patients getting injection 1, 2, 3, and then they just back out and then they do doctor shopping. They feel that the doctor is not good enough. Even after 3 injection, he is telling you for 4th. Even after 3 injection, within a span of 2-3 months of disease of treatment-free time, again I am having lesser vision. No, I am not going back to this doctor. I'll go to a different doctor. So that is a very big headache. Sometimes very demoralizing for the doctors. We feel that what wrong have you done that the patient is not coming back to me after 6 months, or you get from a colleague that yes, someone of patient XYZ came to me and then he has come and I give an injection. So you think what wrong did I do to the patient that he doesn't turn up to me after 6 months? So that's the problem. Those injections could not maintain the vision, couldn't maintain the gain vision. So patient got demoralized, and subsequently when the patient get demoralized and leaves the doctor in the long term will also have suffer a negative effect. So in this context, we need a molecule which can maintain our gain. So definitely Eylea is apart from the other diseases. So what you found that in Violet study, you found Eylea After 1 year level or vision gains were maintained for a long term with a low treatment burden. So very important time, low treatment burden. We are a poor country. People are already burdened. So category of patients are either they are retired, dependent on their sons and daughters for the treatment. So they are dangerous. In many scenarios, and that the attendant wants to treat, patient doesn't want. Patient says that I have already grown old age, already 2 injection given, I don't want to give injection. That is because he knows at home there's a discussion with that 2 months, 2 injection has been done, another three. How can you maintain a family budget? And in front of doctor, patient will refuse. Attendant will act that we have no problem. Go ahead, give the third, fourth, fifth injection. So low treatment burden is most important to maintain and to keep the patient with us. As I tell that I'm not happy giving 10 injection in a day. I am happy in keeping 10 patients who are with me for last 3 years. Means they will stay with me. They have understood that the disease is never going to go. At some point of time, they will require some treatment, and doctor will do whatever is best required for them. So I don't want to give 100 patients and lose 90 and only 10. I want 10. Every year they come to me, whether or not they require treatment or not. So that's very important for low treatment burden, lesser injection, better vision, and this patient will be happy for us. That's very important. It's not important to give many treat many patients. It is important to treat a single patient for 5 years. That only you can bring your practice. That is just a different perspective I'm giving. And I aflibercept. So everywhere they are saying the mean number of injection is lesser in case of in aflibercept. So what are the international recommendation guidelines? So whatever you say that aflibercept is a drug of choice in DME. Definitely, if the cost factor comes down, which you people are telling from April, I can assure you that my number also will increase because I want to pass the best drug to the patient, and as a result, I can keep this patient with me. So aflibercept may lead to a more rapid visual improvement than ranibizumab over 1 year time. That is not only the theoretical I have seen with my eyes that yes, they can maintain the vision. As I say that when the treatment burden decreases, patients' chances of staying with the doctor increases. So superiority of aflibercept was noted in groups of participants with over baseline also, because in this contest I have seen who are the people who have taken Eylea with me. People who have already subjected to different images, to different doctors. So they were no, the earlier doctors were not in my setup. I'm saying they are not brave enough to talk to the patient that we have a drug which is costly, but it can give you some results. In the fear that the patient will leave them. So luckily I got them because they've already been more 3-4 doctors. So patient told me, sir, I am ready. There's a new molecule. Even if it's cost little bit costlier, I can have a try so that I can have some meaningful vision. So, and there is evidence for a possible difference in drug efficacy in patient with DME to the disadvantage of bevacizumab. So there is no comparison from bevacizumab with aflibercept. This is all theoretical part. Eylea is way apart. So aflibercept is now recognized as a standard care in DME and is being used for DRCR network, evaluating anti-VEGF in DME and DR. And what are the effectiveness and differentiation in DME? The summary is that the rapid and increasing vision gains can be achieved and maintained with proactive aflibercept treatment. And all those protocols will say that the main thing is that they can, if I talk in Hindi, then patthar mein phul khila sakte ho. I have seen with aflibercept, it has done it and it has maintained it. It is very easy to gain few lines, decrease the central retinal thickness, but the real challenge is that how long can you keep it even without any treatment? Because that is the game changer in my area where people are not so well off. They are of middle class, lower middle class. They feel very happy that we are giving you 2 injections. They have been gained and this is maintained for last 1 year. And they are happy. They'll come back after 1 year to have one more injections. But they don't want to get at around 5 months injection. Most of the people, I think very few people, last 5 or 6 patients have completed 5 injections. They're happy with the 2. And majority of the patient reaching treatment intervals more than 12 weeks. So they are the factors in medical retina that we have to treat them. The vision has to gain and with minimum effort, minimum and that gain has to be maintained for a long time. If these three factors are achieved, I rest assured the patient will stay with you. So that's all for the presentation, and that if there is any question, I'll be very happy to answer to the best of my ability and my capacity. Dhruva?
Thank you, sir. Thank you, Sujit, sir, for your wonderful presentation. It's a very nice presentation. And thank you, your trust on ILIA. Actually, you are the regular user
Yeah,
of ILIA.
And once the prices come down, I can assure you that we will have more cases. Not only because that drug is good, but the disease-free interval and its repairing capacity is wonderful.
Yeah.
That's not because I'm talking on your platform. That is my that is my perception till now. Because earlier I have used lot of eccentrics, pagan. I have used. They are very good, but maintenance of the disease-free interval, that is the headache, and patient, I have lost many patients only for that.
Yes. So you rightly said. Thank you, sir. And now floor is open for the question. If any question is there, you can directly ask to the Dr. Sujit Aidya. He's a very renowned VR surgeon in Guwahati. He's doing very well. So you can ask your questions. Is there any question? You can put in the chat box also, and you can directly ask to Dr. Sujit Aidya also. If there is no question, then we can close the session. Hello, tech team.
Yes, sir.
Yeah, we can close the session. I think there is no question. We can close the session.
Okay, sir.
Okay. Thank you. Thank you once again, sir. And thank you very much to tech team also.
Dhruva, thank you. Thank you.
Yeah.